Good morning, good afternoon, good evening, everyone. You're welcome to today's episode of Public Health in Real Life, a platform where we hope to highlight key public health issues, celebrate unsung heroes from the field, and inspire the next generation of global public health professionals. According to the World Health Organization, approximately 810 women die every day from preventable causes related to pregnancy and childbirth. In addition, another 6,700 newborns die every day, amounting to about 47% of all under 5 mortalities. Another 2 million babies are stillborn every year, with over 40% occurring during labor. What is interesting about all these stats is Sub Saharan Africa and Southeast Asia contribute to about 80% of all of that overall mortalities. On today's episode, we'll be celebrating World Patient Safety Day, which occurred yesterday, September 17th. But the theme for this year is safe maternal and newborn care, and we'll be highlighting gaps in maternal and newborn care across the globe, solutions that are currently in play, and we will get recommendations on how to act now for safe and respectful childbirth. My co-moderator for today is Faisa Ali. Faisa, welcome to today's show.
Hi, thank you for having me. Yes.
Okay, you're welcome, Faisa. Would you like to tell us a little bit about yourself?
Yes, my name is Faisa Ali. I've been working in global health and social justice for about 7 years. My background is in maternal and child and reproductive health, but my real strength is my ability to advocate, implement, and manage programs. I've worked for international NGOs in conflict areas such in Somalia to low and middle income countries like Uganda, Ethiopia, and Ghana. I've collaborated with the United Nations, USAID, WHO. I've also worked domestically at the Infectious Diseases Society of America, where I served as the policy advisor. My last position was the program manager for the American College of Obstetricians and Gynecologists, where I led programs to decrease maternal mortality in Uganda through safe surgery initiatives. Currently, I am a Master's of Public Health student doing my graduate internship at JAPIGO. Thank you so much.
It's a pleasure to have you on here, Faisa, and to really join me as we introduce our guest, who is not a stranger to this channel, but it was just up to bring her for according to the theme of today. Stembile Mugore, Tembi, as she's fondly called, is originally a native of Zimbabwe. She's a UK trained nurse, midwife, and an MPH holder with over 20 years' experience in global health development. She's currently a senior technical advisor for reproductive, maternal, child health, and family planning with World Vision USA, where she supports technical programming and resource development. In her previous positions, Tembi led and provided technical assistance for health system strengthening with a focus on integrated maternal, newborn, child health, reproductive health, family planning, and HIV/AIDS service delivery and quality of care. And then she has a lot of diverse country and health systems context where she worked, including in Uganda, Tanzania, Kenya, South Sudan, Togo, Senegal, Burkina Faso, and Bangladesh. A champion for maternal, newborn, and child health, as well as family planning and reproductive health, and also for frontline workers that provide these services, Tembi has worked extensively at all levels of health systems with policymakers and program managers, as well as community health workers. And in her many years in global health development, Tembi has had great opportunities to interact with formidable women leaders in the health development sector. Tembi strongly believes that every woman and newborn deserves to have access to quality healthcare before, during, and after pregnancy, including life-saving care whenever it's needed. You're welcome to today's episode, Tembi.
Thank you so much, Maimuna. It's always a pleasure to be on this platform.
Always a pleasure having you. So now to the business of the day. September 17th, as I mentioned earlier, is designated as World Patient Safety Day. And according to the World Health Organization, this day was established to enhance global understanding of patient safety, increase public engagement in the safety of healthcare, and promote global actions to enhance patient safety and reduce harm. Drawing from your vast experience, what would you say are the key drivers to enhancing patient safety and reducing harm?
Yeah, thank you so much for that question. Of course, it is a very broad question, and I think what's important is to look at what harms patients in healthcare, and why does harm occur? Because we can only address what we know. And I think I'm going to divide a response to that question into a couple of categories. One is the entire health systems itself, and the health systems building blocks is defined by WHO. And I'll touch on each of them and how each of them can enhance, if working properly, can enhance patient safety. The other one that I want to touch on is the patient themselves, because they are a partner as far as the safety of the care they receive is concerned. And I'll look at other underlying factors like regulation and what are the various channels or mechanisms for addressing unsafety or harm when it happens. I think the initial response is, let's do no harm. People seek health services because they want to get better, they want their health issues addressed, they want to walk away from any health setting or any contact with a healthcare provider knowing that their health issues will be addressed and they will live longer. That's every patient's wish. They don't go into any health setting expecting anything extra. So now let's look at the health systems. WHO has put the health systems quite rightly in 6 building blocks. And I'll touch on each of them and how it can enhance patient safety. Let's look at leadership and governance. The driver and I'll put it anecdotally. If you are in a vehicle and the driver that is driving that vehicle is not prepared or well prepared to drive, is not well prepared to identify danger and be able to mitigate it, you are likely to have an accident much, much higher. The drivers or the policymakers, the people that allocate resources for health care, really need that in-depth awareness of the importance of their job. In terms of governance, you need policies, you need guidelines that very specifically say exactly what you should do. Just like you will need guidelines that will also say if this does not happen and you are not in compliance with the guideline and somebody comes to harm, there are consequences to that and it can be addressed. So that's part of, and within that, there's also the issue of regulation. Regulation and accreditation on who should provide care. There are a lot of tools, there are a lot of checklists that look at the health setting, the infrastructure, that look at the health systems for patient safety. Are we complying with them? Are they widely known out there, particularly to the end user? That's one part of what I'm talking about in that health system building bucket, which is leadership governance. The second one that I want to touch on is the health workers themselves. I think this is where there is that broad patient safety issues. What do we understand by patient safety? Is it harm And what does that harm look like to a health worker? It starts from the motivation to be a health worker. The motivation to be a health worker is you want to save lives. And when you go with that mind frame into the profession, you are going with that mind frame to definitely save lives. And therefore, saving lives also means in that process, safeguarding lives. Health workers need training. It doesn't matter whether they're a community health worker that we think is not going to do harm. If we are just training them, or if they're passing messages, are those messages going to lead to patient safety? Do they enhance the safety of the patient or the safety of who the recipient of the messages are? So health workers need training. They also need to be regulated. They also need scopes of practice on where are the limitations of what a health worker can do and should not do. I think one of the biggest challenges we are having now in the health workforce profession is shortage of health workers at all levels, particularly where they are needed most, in low resource settings. And as a result, we in the profession are trying our best. What can be safely passed on to lower level health workers without harming the patient? But at the end of the day, are we training people to do that effectively? Are we supporting them to perform those tasks in the realm of task sharing or task shifting or whatever you call it? The third one that I want to touch on after the health workers and their regulation and accreditation is the whole issue of the service delivery. Service delivery has many components to it. One of the biggest components in terms of patient safety is interpersonal relationships between the patient and the provider, and the communication that goes within that. I was thinking of communication in two ways. As I am explaining to a patient what I'm doing to them and what I'm doing for them step by step, is also reminding me, the provider, that what I'm doing is in compliance with the procedures as they are laid down and the policies they are laid down. So it's cross-check. The other one under communication is how free is the communication between patients and their providers. It varies in a lot of places. I have seen and I've heard people say, oh, you don't question what they're saying, they get annoyed because they're supposed to know better. But I think the patient also has the onus to be able to communicate, and that environment should be so conducive that patients are able to say, you know what, I actually came because it's my lower abdomen which is painful, not my chest. It's simple as that. Or that yesterday I was given 2 pills, today how come I'm just getting 1? Because those are some of the errors that happen. Within the service delivery is the whole infrastructure. And I don't want to touch more about infrastructure, but there are instances where just the infrastructure needs to be in a way that enhances patient safety. We were talking about power outages. We were talking about lack of running water, basic sanitation within the health facilities. We can talk about infection prevention practices. We can talk about shortage of equipment and things like that. That all these things should be in place to enhance patient safety. If a lower level, right from a hospital, and these departments that are supposed to provide care should be fully equipped to provide that care, and all the equipment in there should be functional. that comes to resource allocation, financing of the health services. We see a lot of inequities within countries, rural, urban, geographic areas, and across countries, and even globally, where you seek health services matters most. Where you find yourself when you're pregnant should not be a determinant of whether you walk out of that place with a live baby or you walk out alive as a mother. That's the health system and financing and allocation to those health systems. A lot of patient safety also has to do with drugs, mislabeling of drugs. That goes back to very much these pharmaceutical companies. Sometimes I've seen drugs that look like the labeling is fairly similar. And even in the private sector, the ones that you can access. And unless there is cross checks and balances throughout the system, right down to the patient, that there is regulation of labeling of drugs, there is regulation of what to do with the life cycle of drugs, that they should be properly labeled with expiry dates, what to do if they expire. You have big challenges. That's one of, if they are available. But I talked about in the service delivery system, if a service delivery facility or provider is supposed to provide malaria treatment, let me go basic to what is common in Africa, that should be available to them. The effective drugs should be available to them, because that then, if those are not available, is tantamount to contributing to harming patients, because by the time they are seeking care to the next level, it might be too late. And the last one that I want to touch about, that is patient safety, is the health information system. The health information system, that where data is used for accountability, where data is used for decision making. I'm talking now, basic data is post-operatively, how many infections are reported from the post-operative procedures, how many infections are reported from maternity care, how many cases could have been avoided had, let's say, drugs been in place, or how many patients fall off their bed, or elderly patients or fall off their bed at night. And when that data is available, I think in the health system, sometimes we tend to be protective of the care that we give. But I think we need transparency for accountability to take place. As health workers, we need to hold ourselves accountable for the care that we provide. And using data to inform policies, using data, interrogating data, and asking those why questions will help a lot in enhancing patient safety, because we have to identify what is wrong within our system that could be creating harm, and be able to mitigate that harm for patients. So you need very effective data use. I know we tend to count how many deliveries, we tend to count how many new alive born babies, how many stillbirths, but that data needs to tell the complete story. That data needs to communicate why. And the last one that I want to talk about is getting the communities engaged. I think patients should never be like passive recipients of care. It takes a lot of empowering patients to be able to voice, to be able to talk, to be able to understand what is happening in their health systems, and to be able to make those demands for the health care that they expect, and to be able to ask what happened when their old grandmother fell off the bed in hospital and ended up with a fracture. What happened with the baby that went into hospital for care and ended up with infection? And really get very, very satisfactory answers. I think we find in different settings where in the US, health workers fear litigation, and therefore they are likely to document, they are likely to do better. And then you have in some low-income countries, sub-Saharan Africa, where I come from, there's, oh, sorry, this happened, or the infection happened, what happened? So those things, I think you need to create a balance. We need to empower patients to be able to talk, to be able to voice that, no, this is not what I came for, and to be able to ask questions. I personally like patients to be partners in their healthcare rather than passive recipients of care, and including, and I'm talking patients in the broader sense, because it's just the patient themselves, but the patient comes within a family context and communicating with whoever they say is their next of kin. And I think I'll end there. The other one is, of course, regulation and accreditation, ensuring that there is proper regulation mechanisms in place and proper accreditation of healthcare providers will go a long way in enhancing patient safety. And above all, the professionalism. And I think as health professionals, and our professional ethics should lead us to be advocate for better healthcare, for creating an environment that enhance patient safety, because that's basically what we are. At the bottom of the line, we go in to save lives, very simplistic like.
Thank you so much, Chembele. That is, your experience is very impressive, and the fact that you broke it down in a very understandable way is really good. One of the comments that you've made that really resonated was that patients shouldn't be passive recipients of health. And as Maimunat said, the theme of this year's of this year is safe maternal and newborn care, with the urge to act now for safe and respectful childbirth. So, in reference to that, can you define what a safe and respectful childbirth experience is?
Okay, thanks so much for honing into something that is dear, very, very dear to me. I think one of the things Maimuna in the introduction did mention and allude to is the maternal deaths. We are not even counting the morbidities. But we believe that for every maternal death, just count at least 40% in terms of morbidities. Morbidities due to infection, morbidities that are long-term because somebody has bled, and therefore it affects their kidneys in the long run. I think if I also just go back to divide that, you already mentioned respectful care. The experience any woman and her family have throughout pregnancy can be equated to their safety. And that experience comes to communication. Communication from the very time they make contact with a healthcare provider to say that they are pregnant, they need care. That needs to be brought into the picture. Again, maternal health services are provided at different levels, right from the lower level health facility. Do we have skilled birth attendants that any person who is able to go there seeking care can get care? That's one. Do they have the equipment? Do they have, as health workers, the skills to be able to do that? It doesn't mean that everybody should be doing a delivery, but they should be able to be aware when to refer and where to refer to, and referral procedures right from the community itself. That for me is fundamental and very key, that communities or the patient itself and the families that are caring for them understand where to seek care, when to seek care, and what to expect of that care. So that they're saying, you know what, I went to the clinic, or you forgot to check my blood pressure, or you didn't take my urine specimen, and be able to talk about that. That's one. And I think once everybody understands what to expect, then they can demand it. They can demand, and I'm talking demand in a soft kind of way, or serve as a reminder for themselves. Respectful care means that the people that are midwifery education does a lot in helping midwives and skilling them to understand the changes, the mental, physiology, physical changes that happen in pregnancy. And they do that very, very well. But sometimes midwives, sometimes healthcare providers find themselves in situations that are challenging, that are overwhelming, that they don't understand the balance between, yes, I'm slapping you in labor so that you push. That is really, at the end of the day, doing harm than doing right. I think that partnership needs to happen right at the beginning. The other one is looking at quality of care. Safety is a key component of what is described as quality of care under WHO. What does that safety look like? And it needs to be shredded into pieces. Safety, it does not mean that I fall or I get the wrong drug. Safety means that mentally, physically, and physiologically, I experience care that is to be expected. That if a health facility has to have oxygen, it should have oxygen, and that oxygen should be administered timely. If that health facility is supposed to check my blood pressure, that blood pressure, functional blood pressure machine should be there, and it should be functional. That if midwives are supposed to communicate with me every stage of what should happen and what to expect at pregnancy stage, that should be communicated. And I think a friendly maternal environment also produces very friendly mothers. I think that's really key. Every woman, we know there are going to be accidents. Accidents are fewer. Everybody who is pregnant, remember that at the onset of pregnancy, most of the women are healthy and they are at the prime of their health. They become pregnant, things should not change, and we should work with that benefit to ensure that the end result is that they're able to walk out of a health facility or able to walk out at the end of delivery healthy, mentally, physically, and with a healthy baby who is going to thrive later on in life.
Wow, Tembi, it's great how you talked about just those different components of health, not just the actual physical care, but mental, psychological, physiological, as you said, in that concept of respect, safe and respectful childbirth. As you know, we often talk about social determinants of health in public and global health, and you had mentioned earlier about all the different contributors to health outcomes. There was this article recently published by Nigeria Health Watch where they talked about the impact of gender inequality on maternal care. Can you elaborate a little bit on that?
I think it goes back, gender inequality. We talk a lot about it. I think it's published, but some of it is inherent, and some of it is inequalities. Part of the barriers to safe maternal health, and it's something that is being addressed and will continually be addressed. Let's talk of women's agency. Women know when they're pregnant, they know what to do. They know that they need to seek care and where to seek care from. Their objective is that they need to see that pregnancy to term. I think in the African context, in our context, it's very taboo not to be pregnant and either have a miscarriage, or to be pregnant and come out with no live child in our societies, because the expectation is that part of what defines you as a woman is your ability to be pregnant, carry pregnancy to term, and deliver a live baby, or have as many babies as the family desires. And if that does not happen, a lot of young women get discriminated against in society. They get marginalized, and there's this feeling of inadequacy. And yet, there's a lot that our societal norms determine that limits their agency, that limits their capacity to take action on their desire to seek care. Let's go on. Who controls decision making within a household? Who controls the resources within the household? And who controls even movement in sometimes of the young brides? The husband, who is a product of older generations of men within that community, who has this information passed, because they control the resources. Even if the women are the ones who do the digging and marketing of things, the resources and how those resources are spent come from the husband's pocket. That's one. Who controls whether to seek care or not to seek care? Sometimes it's the older women in the homestead, mother-in-law or sister-in-law within that. And they sometimes base their advice, they base what you should do or not do on their own experience. There's nothing scientific about it. On their own experience, what they did and what they did not do. I think that all those that whole area, or those social norms that contribute to women not being able to make decisions and act on those decisions to seek care, or to even share that today I'm not feeling well, without being labeled as lazy, or without being labeled as trying to avoid something, or without being labeled as weak. It's a very simple, basic foundations of inequality. And I think with the older generation, with the younger generation coming up with access to information, I think the ground is shifting. It might not be shifting fast enough to the majority of women, particularly in the rural areas, in rural Africa, I'm going to talk about. But it is shifting, because the husband becomes part of that shifting change, and they have more access to information than reliance on just their older generation, their dads, their older brothers, their uncles, on how do you handle a woman, or how do you diff out or put out the resources within the homestead, how do you make decisions for accessing health care. The other one, I think, that comes to inequality, if you look at the infrastructure, I've traveled a lot in a lot of countries in Africa, just like I trained in the UK. We try to say, let's involve the men in antenatal care. Let's involve the men in delivery. That is also a journey that we are going, because the infrastructure sometimes just doesn't enable. There are delivery rooms that virtually are like just cubicles separated by a curtain. How do you have somebody's husband there, even if that husband wanted to be there? I think the other thing, it also points to inequality. I had C-sections. I had my husband in those C-sections. But I belonged to a different wealth quintile, education quintile, urban, better access to private healthcare, or even better public sector healthcare than my rural counterparts. And I think that is also inequality. This is what I talked about. Where I live, where I become pregnant, find myself pregnancy, should not determine the outcome of my pregnancy. But that's the bottom line, really. Urban, rural, urban slums, urban middle class dwellings, developing low income, educated, not less educated, higher wealth quintile, lower wealth quintile. I think some of those inequalities are what we need to address if we are to meet that sustainable development goal that says countries should strive to reduce maternal mortality to 70 per 100,000 live births. It's societal itself. It's the health system again, we come to it, and it's just the way the globe is in terms of inequalities. But I think we need to empower not just women, but we also need to empower communities. We need to empower the young generation of women. We need to empower health workers, that change can happen, and we are living in a different era.
I'm actually speechless momentarily, just as you really delved into those different social determinants of health that allow for inequities. Warren Buffett was said to have mentioned the concept of him winning the ovarian lottery, just by virtue of he having access to certain things because of where his mother happened to be, the circumstances of his birth, and where he lives. And you've just shed light on that very succinctly, that even within countries, within areas, within environments, disparities exist for a myriad of factors. You had mentioned previously health workers as part of this 6 building blocks, and you also highlighted on the shortage of healthcare workers, globally, but then more so in lower resource settings. So, what would you think? And in the concept of maternal deaths, we've mentioned that a lot of them are preventable, and it's often also due to lack of access to skilled health professionals, due to a host of other factors, the 3 stages of delay, like you mentioned. So, could you quickly elaborate on, 3 strategic options that we have, or anybody in, government or in a position of power, 3 strategic options that they have to address gaps in HR in maternal and newborn care?
I think that's a big challenge. I think we normally say train more midwives. I've heard that a lot. Train more midwives. They get trained. How do you deploy them? What are deployment policies like? I think that's a big issue. A number of countries have come up with very innovative deployment policies to have skilled maternity care at the lowest level. I think we need to look at the continuum of care. We need to look at the different levels of health facilities, and treat everybody as a team from the tertiary hospital right down, a seamless thread, a thread that runs down to the pregnant woman themselves and their family. There are a number of things that, or there's care that can be taken to the patient and her family, or the community that supports her, the mother-in-law and everybody. That comes with education, understanding what to expect and what not to expect, and when to seek care, and how to seek care, and what's timely care. That's very, very critical. And unfortunately, I think I was reading some country which I won't mention of just that information, women not understanding that it's not okay to bleed when you're pregnant, and therefore not seeking care until it's very, very late. And yet there was a whole program that was addressing that. That's one. And two, using those traditional structures, I think picking out what is positive that we can build on in those traditional cultures, and that we can build on with scientific knowledge and information that will help care for these pregnant women. That's one. The lower level care provider is usually your skilled birth attendant or your community health worker. What skills can you give them? They can observe. Some of them are mothers themselves, so some of them are a lot more experienced. But what is correct and incorrect, what can change and not change, and what action should they take? Give them the skills, but also give them the tools and support them to be able to provide that care at that level, and to be able to know when they should move to the next level of care without delay. I used to say to the midwives, you know what, if the bus is your only source of transport in this area to go to take anybody to the hospital, if she is still in labor and she is not progressing, make sure she's on that bus, on that last bus when it goes to town. Don't be stuck in the middle of the night running around looking for transport in the village to transfer a woman. Unfortunately, for most cases, it's too late. By the time they get to care, they just don't make it, or they get to that level of care too late for anybody to save their lives. So it's that equipping people with decision-making capacity, plus the means to be able to move to the next level of care. There's a lot that has been said about task sharing, who can do C-sections. Countries have tried. Mozambique tried with trained midwives to do C-sections. They were safe, but they also ran into issues where that safety means that those midwives were equipped, they were supported to be able to do those C-sections. And it kind of falls flat in that lack of equipment, lack of support, and lack of just the infrastructure to be able to provide safe care. We train people. I was trained in an urban setting and ending up in a rural health facility with very low resources, could be a challenge for me to practice effectively. And I think there's re-looking right now at education of OBGYNs, education of midwives, and ensuring that they get that rural experience. And I think in some places, people have tried to get communities to demand accountability for ensuring that their local health facility, if it's supposed to provide maternal health care, it's equipped to do that. And there is a midwife there. If it's supposed to provide C-sections, that it's equipped to do that. And there is a doctor or a clinician who can do that. And I think that's one. And I've also seen cases where communities have said, okay, if housing for this midwife is an issue, we will provide the housing. But it's an entire health system that needs to be able to function and function effectively. I think if you look at, sometimes it's not just the health systems, it goes back to the inequities. Take the US is not a low-income country. It's very highly developed, and yet there are pockets of communities in this country where maternal mortality is just as high as some of the countries in Africa, and it's amongst the African American community. To look at why is that? What are we doing wrong? How are we interrogating the data? How are we letting women down? I think the default has always been shortage of health workers. We don't have midwives. Yeah, if you don't have midwives, then tell people, are we telling them not to become pregnant? No, I think it's really working with those community structures and saying, for all those things that we can do, what can we do at each level? Because WHO has come up with self-care guidelines, which are very good. And I think there's room for expansion there. Technology is coming up. I think whilst we are saying people can test themselves, can do self-testing pregnancy tests to know whether they're pregnant or not, we can actually also do the same pregnancy test for women to understand that they can test for protein in their urine when they are pregnant, or they can have access to where they can check their blood pressure without necessarily taking a professional person or trained person to be able to do that. So it's shared, and it's the reality. I think life has to move on, and we have to work with what is available and what we have. And what we have is the communities themselves and the individual pregnant women themselves and their immediate families, the community that they come after, plus the entire health care from their lowest level of provider, who is their community health worker or trained traditional birth attendant.
Yeah, Tembi, thank you so much. Now, I really agree with you that a comprehensive and cohesive team needs to function in order to safeguard the patient. An unskilled health worker can become detrimental not only to the patient, but the whole health system. That is why team training, I believe, and that's what you mentioned, is essential for the hospital to work like a well-oiled machine. I mentioned that in my past work, I've collaborated with American doctors to present simulation-based training to hospitals with limited resources in Uganda. However, the pelvic models we were using were so expensive and required outside funding. So from your observations, what are successful innovations that have been developed and deployed in resource-limited settings to address gaps in maternal and newborn care?
I think there has been a lot in terms of innovations that are coming up and emerging every day. I am sometimes am averse to saying it's an innovation. Yes, it's an innovation in those low resource settings. Some of the innovations that I'm seeing were not innovations when I was doing my midwifery training in the UK, but they are innovation in low resource settings. Again, what I have appreciated and liked myself is that the innovations are using what is available. They are using the community, and they are using like the mother themselves. And an example that I really commend that is using the mother themselves in the absence of an incubator is the kangaroo birth care. They're just using the mother themselves. There's no much technology required there. And they're using what probably was happening traditionally in olden times, except that it has been documented, the effectiveness of it has been found. It just as an example of really like various innovations. Technology, I like technology. And I think it has a lot of space in what we are doing, a lot of space in empowering people with information, a lot of space in empowering or enabling communication, enabling questions to be asked, enabling somebody to say, I did not sleep well last night. What do you think is happening? I think that's another piece of innovation that we are seeing. I think the other one that really is just kind of different innovations is better involvement of communities as change agents. There are a number of organizations, even the ones that I'm working with right now, World Vision, it really works with communities and engages communities to be change agents, whether it's community leaders, whether it's faith leaders, looking at who is respected in the community that we can make change agents. I think those are some of the structures that I can think of without the hardcore technical things that are coming up. I think there is a whole focus on, if you don't want to have malaria, and I remember there's an Irish doctor who said that if you don't want to have malaria attend in Uganda, don't get bitten by a mosquito. It's as simple as that. And I think the innovations that I'm seeing are actually pointing a lot more to that simplistic. If you don't want the woman to bleed after delivery, you better make sure that when she delivers, there is everything. She doesn't enter pregnancy anemic. That's one. And that you are able to actually anticipate who is likely to bleed and ensure that there are resources to help with that bleeding when it happens. And if it happens, and that there are quick resources to happen. And I think whilst we are calling them innovation, I think there's a lot of, I want to always say to it's more common sense. I think health professionals, we are needing more and more common sense, and we are erring on the side of common sense and saying, yes, we are professionals, but we cannot do it alone. We need to do it with the patients. We need to do it with the clients. We need to do it with the families. We need to do it with the communities where they come from. And for me, those are emerging innovations. And I want to commend a lot of organizations that are throwing a lot of focus on just what can we do differently to reduce maternal mortality, to reduce newborn mortality, and to also ensure that pregnancy does no harm to anybody's life.
Thank you. No, it's very revolutionary what you're talking about, just by not trying to reinvent the wheel in terms of innovations. And there's some things that have been going on for centuries that we're trying to completely rework, but have been working in the past. So sometimes in those contexts and in those settings, it's probably not best to introduce something that might be harmful, or it's very difficult for the health system to adopt. So that's really important. In these type of forums and in most of stories told about maternal health, we always are talking about the negative impacts, a very grim portrait that we're portraying about maternal health and maternal disparities and things like that. So can you share a field story about a childbirth where you managed a positive outcome for both mom and baby?
I have a lot of them. I think part of why I enjoyed midwifery a lot more was I trained and I worked my early midwifery days in a setting where we could save lives. And there was nothing as satisfying to any midwife was to walk that patient when they were leaving the hospital with their family or the husband or the partner there and their baby all nice. I think that is very, very critical. But I think what I found a lot more satisfying in my work is that one life you save. The one we call near miss in our language, the one you know that person could have easily died, and it lives with you for years. There are women that I can see right now, and I'm going to cite two. I will not cite the countries. We're doing a needs assessment in a country, and everybody just seemed to be running around. And as a midwife, and I always say that to people, that if you have never experienced a bleeding uterus immediately after delivery and the patient almost dying, and you doing something to save that woman and just saying, okay, let me take over, let me try and do by manual compression, get this drug, do this, you don't feel that satisfaction. And I remember that very well in that very first case that I had, that adrenaline rush, which then says, you know what, 20-something-year-old, she's going to die. And very quickly coming to your senses and saying, what I have is this, and surrounded by people that can get this drug, please run to the pharmacy and do this. That I remember very, very well. Unfortunately, I don't want to say I've seen it a couple of times. And you say to yourself, let's look back. What happened? Should it have happened? What could we have done? And then now we are now putting yourself, what could the system have done to just make sure that it does not happen at this stage? I think that's one that I remember, and those live with you all the time, because when they live with you, they live with me, not for the life saved, but also for looking back and saying it could have been avoided. It could have been avoided if this had happened and this has happened and this has happened. And you don't want those very near misses to be teaching opportunities for the younger generation of midwives, but they do. They did for me and they do for them. That I remember very well. The other one I also remember is a young woman in a country. I happened to be there. We were training young midwives, doing refresher training. And when she got brought to the hospital, I think they went to get her husband who came from the field, and I can even see him right now, mud up to his knees. And he was standing there. He didn't know what was happening. And she was almost like starting to fit. She was going into an eclamptic fit. And that's very, very scary. And I remember saying to the other midwives that I was in that, she's too young to die. And that man will never live with himself, because he just looked very, very scared. He knew there was something wrong, but he looked very, very scared. And I think those live with you a lot more when they walk out. But it's also that maternal death lives with you, and it haunts you for years. The fresh stillbirth that happens within a health facility also lives with you, and it haunts you for many years, because you can see those babies, the fresh ones. So there's a lot that is midwives that you remember and that lives with you. But it's that story of life saved that those become very, very more interesting, because they definitely live with you. And I have a number of them, and I have numbers that I've also witnessed. Some great midwives out there that I've seen literally just with their bare hands save lives.
That's a very poignant story, and as somebody who has also worked in trained and worked in resource limited settings and experienced some of that, you mentioned, I actually wrote a piece on LinkedIn about it. Like you said, it lives with you, where I had to use plain gloves to take out a retained placenta, reaching far into the
Yeah.
wonders without electricity, if I would
Mm,
add.
mm,
And those things live with you. And to the point you mentioned earlier about, you don't just see the data, you ask why. And
yeah.
then you ask yourself what you can do to change. Because next time, put in that kind of situation, that patient is not likely going to make it. And that also lives with you as well.
Mm-hmm.
We're definitely past the hour, and I know we we have some audience questions, and I want to just get to that. You had already answered this, but I think just wanted to show it in case there was anything else you wanted to just add to what you've said previously. So this is from Aishat A. It says, thanks, Stembile. In your opinion, what are the interventions or methods that can be devised to curb the rate of maternal and newborn deaths and morbidities, which like you mentioned, we hadn't addressed in low income countries, particularly?
I think it's a broad question. I think there are a lot of things that we need to address. One of them is, how do we address those health determinants, those social determinants that affect, or that we know further down the line can contribute to better health outcomes? And I don't want to just focus on maternal newborn, but better health outcomes for everybody, male or female. I think it's basic things like ensuring that girls everywhere have equal access to education, and that we have more girls getting as far as high school, as far as college, that the sky should be the limit for any girl child, regardless of where they are born. I think would be a beginning of changing or addressing some of the disparities or some of the inequities that eventually evolve into where people are vulnerable when they become pregnant later on in life. For me, some of those disparities are key to address. The other one is looking at who is coming into the health profession, how do we better equip them to appreciate and to value themselves, to feel their self-worth, that the work that they are doing is very, very critical beyond just saving lives, but is very critical to the development of any country. I think, and recognizing that, and I think governments recognizing that and appreciating that. There's a lot of low morale amongst health workers. They feel left behind, particularly nurses and midwives. But how do we go around that curve? The health systems. I think health systems have to be there to save lives. Are we addressing the inequities in health systems within countries, starting within countries, the global inequities in health systems, that we are all equal on one side, but we are situationally or contextually equal? I think those things need to be addressed. There is a global movement. I think there are a lot of organizations that are doing a lot of advocacy, and I think they need to be encouraged. They really need to be encouraged. We are seeing the private sector for profit coming into this arena. And I think it has to do with just these advocates, people like you, Maimuna, people like you, Faisal, just putting the message out there to whoever can hear and whoever will hear and get the message. And I think, like I said to somebody, let's keep talking until we talk no more, until our voices, somebody somewhere hears us. I think we are where we are right now because there are people who have advocated for these issues. And let's keep that thumb pressed on that advocacy button to address those broader issues. I think the other one is, let's also look at the issues of rights. I think we talk about rights. It has to do with social justice. What are the consequences of things that, or governments not providing just basic care and ensuring basic care for everybody? I don't want to talk about just pregnant women, because that's where it starts. The girl child who is healthy is likely to be, the pregnant woman who is healthy is likely to be a healthy mother, mentally and physically. I think there are a lot of things that we should encourage innovation, and we should fund innovation. People should put we should put our mouth where we should put our money where our mouths are. There's just so much in terms of development, so much in terms of technology that can be tapped into. There are a lot of brains, even in low income countries, that are very innovative. And those innovations, unfortunately, don't go anywhere. Some of them end up as just small pilots, boutique somewhere else, and they are not scaled up because there is no funding to do that. I think when we are talking of universal health coverage, when we're talking of the sustainable development goals, that momentum needs to be accompanied by ensuring that the resources are available for us to attain it. They are available in a very, very poor country, in the poorest country in the world, just like they're available in the high developed country in the world. I think equitable distribution of resources needs to be looked at. I think that's where things have to be homegrown. Some of the things that we package as innovations are definitely homegrown, and there are a lot of very innovative midwives that I've seen and come across. And yet, because what they do is not documented, it's not supported with any funding, it's just that once-off thing they do and it ends there. I think we need to encourage the future generation of midwives that are coming into training, nurses, doctors, everybody, that they can be as innovative as they can. They can write the textbook for their context, and they can make a change, because that's basically, a lot of them live that. They can, and they need to be encouraged. They need to be, people are coming up again with innovative grants here and there, but they're not spreading wide enough to encourage innovation. And sometimes the grant is just that you get the grant and it ends there, and there's no scale up. I think there is need for that, to just embrace the change, and allow these homegrown innovators to come up, and give them the platforms to be able to share. I think there's a lot that can be done, and that is being done, but it needs to again go back. It always has to go back to context. But we need to start, my girl child and somebody's girl child in rural Zimbabwe should not have the odds stacked against them from birth. But
Yeah.
unfortunately, it's happening. The
Yeah.
odds are stacked against them from birth.
Yeah, yeah. It goes back to what we said earlier about that whole it's funny because it's almost like a pun that Warren Buffett used when he said ovarian lottery. He just said it
Yeah.
randomly, but the fact that we are using the ovaries, which is part of, the woman's reproductive system, on a day like this makes it even more poignant.
Yeah, it does.
It's and Tempe, you've touched on everything. Just answering that question, you've been able to summarize all of the different components that go into ensuring, access to health, and digging into those, social and other determinants of health. And also you've talked about, the inequities. And I think lastly, you talked about, which you touched on or you alluded to, the power dynamics and that changing, which we wouldn't necessarily address today, that growing movement of, decolonizing global health and
Mhm.
trying to change the power structures and dynamics between north-south collaborations and, allowing for more south-south collaborations, as well as highlighting voices from the field to showcase that a lot of things happening are actually reverse innovation.
Mhm.
This brings me to the next question. In one sentence, because you kind of like touched on it, but in one sentence, what legacy do you hope to leave for the next generation of nurse midwives and maternal and newborn care advocates?
Oh, in one sentence. Okay, I think I'm here on the backbone of midwives that whose names I can real big names. The legacy that I want to leave the next generation of midwives and nurses is to remember that their job is so critical to human development that they need to hold themselves high and have self-worthy and be accountable for every action that they take in saving lives. That's really the message that I can give. And let's keep talking, let's keep advocating until, like somebody said, no woman dies because the only thing they did was to exercise something that is very basic in their lives, which is they wanted to be a mother.
Thank you so much, Tembi. I mean, that reminds me of when I was, what inspired me to get into maternal health is working in the rural areas of Somalia and being an advocate and implementing programs to deter young women and their mothers from committing the harmful acts of female genital mutilation. So that it was plaguing my culture, my people. So that was something that I decided to do. And while I was working in that initiative, a quote that I will never forget that really propelled my to champion my interest to champion for this field was, "No woman should die while giving life." And that was a event in a seminar that I was listening to by the Secretary General at the time, by Kim Moon. He named that while he was presenting a program on a female genital mutilation in Kenya and Somalia. And that was something that is so simple quote, but has resonated with me throughout my life. So I think that's what I would encourage our viewers and our supporters to really sit there and just think about that quote. And that really encompasses what we were talking about, is no woman should die while giving life. And I think that's really powerful. So thank you so much, Stembile.
Thank you.
Mm-hmm.
Thank you, Faiza. That's really powerful. There's really nothing more to add to that beautiful quote and story you shared. To our audience, we thank you for joining us, for your patience. As you can see, Tembi is a wealth of knowledge, and this is why she's a favorite on our channel. So, we hope to continue this conversation. And like Tembi said, let's keep talking about it in our different corners. Let's keep advocating and spreading the word till we move the needle in maternal and newborn care. And please subscribe to our channel. If there are any key issues you want us to highlight, or people like Tembi, amazing people working from the field, we would want to celebrate such heroes on our channel and on our platform. So please feel free to reach out to us. Once again, thank you all for your time. Thank you, Tembi. Thank you to my co-moderator, Faiza. It was amazing having you on here. Everyone, please be safe and be well.
Thank you.
Thank you.
Thank you.